Noon, and welcome to Mayo Clinic's Cancer Conversations on prostate cancer. Our topic today is health literacy and patient and caregiver communication of treatment. My name is Christine Samuel, and I'm a community engagement coordinator here at Mayo Clinic in the Center for Health Equity and Community Engagement Research, as well as the program coordinator for the Coalition of Blacks Against Cancer. And today I will serve as your moderator for this afternoon's prostate cancer conversation. And we are so happy that all of you could join us today. During this hour, you will hear from our dynamic speakers today. First being Mr. Cedric Walker, a prostate cancer survivor, Dr. Donald Norfelt, a hematologist oncologist at Mayo Clinic and the Arizona site director for the Center for Health Equity, as well as Dr. Ewan Coburn, senior associate consultant. And Dr. Coburn's research investigates the relationship between medically underserved populations, genomics, genetic literacy, communications between patients and healthcare providers, and prostate cancer disparities and health equity. To begin, prostate cancer is an abnormal growth of cells in the prostate gland, which is found in males. It is the most commonly diagnosed cancer among American men after skin cancer. However, rates of prostate cancer vary among different groups of people. 1 in 8 men will be diagnosed with prostate cancer during their lifetime, and for Black men, 1 in 6 will be diagnosed with prostate cancer in their lifetime. And Black men are disproportionately affected by prostate cancer and often have earlier presentation at an earlier age and sometimes more aggressive disease due to when it's found, as well as a higher mortality rate. And now that you've heard the facts, I will pass it over to Mr. Cedric Walker to share his prostate cancer journey.
Hello, everyone. My name is Cedric Walker. Thank you, Christine, for your introduction. My prostate cancer journey started right at the beginning of 2020. I took a job to where I worked somewhat in the medical field. I'm an epic analyst, and I was traveling when I first started this profession around 2013, 2014. So I took a local job to where I didn't have to travel. And of course, when I started traveling, you know, when you're going to hospitals and you're going to be around patients and everyone, you have to keep your health up, shot records, et cetera, getting checked by providers for various diseases, flu shots, or what have you. So when I stopped traveling and took a job just at a desk or what have you, of course, I stopped going to the doctor on a regular like I should have been doing. So this was around 2017, 2018, maybe the last time I had been to the doctor. So right at 2020, the beginning of 2020, I put in to have an appointment with the doctor. This was about March of 2020. Of course, that was right at the onset of COVID. So everything got pushed from March of 2020 to my appointment being pushed to July of 2020. And they were like, well, we can do it virtually. We can do it over the phone. I said, no, I need to come in because I need to be tested and I need basically hands laid on me. And so y'all can, poke and prod like you usually do. So I went in July, ran a few tests. Initially, they saw that there was an issue, may have been an issue with my heart, sent me to a cardiologist. Everything checked out fine. On those visits, though, my PCP, she checked my PSA, and she noted it was high, a little bit high the first time. She didn't really say anything. So when I came back, July, August, after the cardiologist, she said, your PSA was a little high. We're going to send you, going to schedule you a visit to the urologist. I said, okay. So by the time I got scheduled and visit, this was August of 2020. Went in, did an exam. Said he felt, maybe a nodule or two on my prostate. Set up a biopsy. Tests came back. He actually told me that day that there was probably 60 to 70% chance that I might have prostate cancer. Not to be alarmed, but he do the biopsy to find out exactly what was going on. So did the biopsy, called me back in the office. This was September, October of 20. Showed me the exam, showed me I had a small spot on my prostate I think he said it was like in the area 7, 8, and 11. He was very detailed in his findings and let me know what was going on. Um, the good part was they had caught it early. It was slow moving. And at that time, people always ask me, well, did you feel something or did you notice anything? Why did you go? I said, no, I was just going for a regular checkup because I hadn't been in a couple of years. So from there, went to, he gave me my options of what I would need to do since at that time, I was, what was I, 55 years old. He told me since it wasn't aggressive and it wasn't at any increased stage or risk of anything, he said he would recommend the radiation treatment. He said I was just past the number. I believe the number is 7.0. My reading was 7.4, 7.5. And he stated had you came in about 12 months to 18 months earlier, we could have treated this with medication. But now that you're past that point, we're going to recommend that you do a series of radiation treatments. So I said, okay, that sounds good. I wasn't interested in having my prostate removed. So went with the scheduling of the radiation treatments. With this being at the end of the year, of course, it's not a fast track process. So I didn't really start my treatments until March of 2021, the following year. It was supposed to be a series of, I forgot the exact amount. I think it's like 39 treatments or something like that. What I did was I went to the oncology clinic Monday through Friday, same time pretty much every day. The treatment lasted, the office visit never lasted any longer than 30 minutes. The treatment itself was probably anywhere from 10 to 12 minutes in the radiation room. Everything went fine. Did this all the way through March, all the way through April. Then in May, the plan was I was going to take 2/3 of the treatment and then get the last 1/3 of treatment over a weekend stay at the hospital to kind of, like they said, the small treatments they give it to you in dosages to where your body gets used to the radiation. So then after that, you get the larger dose to where you just kind of knock the cancer on out. Well, I had a small complication, uh, nothing due to the fact of anything that was wrong with the cancer or my body. Something just happened to where we had to stop the procedure, didn't go through with it. They let my body rest for a couple of months, June, July, and I started the treatments back up in July. Since I only had like 13 treatments, they condensed those into like, I want to say 3, maybe 4 treatments, which were every other day for about 2 weeks. I think I would go on a Tuesday, then Thursday, and then Tuesday, Thursday of the following week. I believe that's how it went. So long story short, I finished my treatments, daily treatments by the end of July. I went back and visited my urologist. Well, it was probably September, and he said the radiation had did its job. My PSA has dropped significantly. From there, I've been visiting my primary care physician and urologist, usually about a week apart, starting in January of 2022. So I've been going to them every 6 months since then. My last visit was July of this year. My PSA is down to like 1 point something. Like I said, I was in fairly good health. I've never really been in the hospital or had any issues. So didn't have any other issues. I'm scheduled to visit with them again in January of this year. Like I said, every 6 months. So far, everything has been pretty good. I have no complaints about anything or the treatment that I received. Just glad that they did catch it early. If any of you see the commercials on TV about the early catch, I know they show them on Sundays during the NFL, but I'm not sure about the other other times they broadcast them. But that's very true. If they catch it early, they definitely have a better chance of treating you, and your survival rate is much higher if they catch it early and everything is treatable.
Thank you for sharing your story, Mr. Walker. And when you were going through your journey, is there any advice that you would give to other people on their prostate cancer journey about asking questions to their doctor for clarification or anything related?
Yes, just make sure you ask the right questions, and don't be afraid to, like I said, I was at the age, like I said, I was 55, and I'd had people that I knew in our community that were older than me, some even younger than me, that already had issues with prostate cancer. Actually, my father had to have his removed when he was well, I think he was right at 60 something, right at 60, maybe 61 when he just went ahead and had his removed. So I had someone right there that I could talk to. Of course, I talked to several other people. The main thing is to be clear on exactly where you are in the process, how aggressive your prostate cancer is. Like I said, mine wasn't really aggressive and it had spread. That's not the case with everyone. Um, just make sure you're getting the correct information. If you don't feel comfortable answering the questions, you can take someone with you that may have a little bit more medical background, or they can let you know what questions you need to ask. Like I said, I'm an Epic analyst, so I know a little bit of the medical terminology and a little bit of the background on prostate cancer. So I was able to ask, important questions or questions that I feel were important. Like I said, just kind of a time frame, how the radiation was going to affect me. Like I said, the funny part is the daily radiation, I didn't really feel. I started feeling the radiation after my treatments ended, basically. I was feeling somewhat normal from when I started in March all the way through July. Um, my issue started where I could really feel it, or feeling tired and sluggish. That came, I would say, starting in maybe like a month after. And everybody's body is different, so I'm pretty sure everybody is affected different. But I've really started feeling it come September, October, November, to where I really felt different from what I was usually feeling. Um, and that lingered for a while. I mean, I still feel tired and sluggish these days. I'm not sure if that has anything to do with it, but it becomes more of a mental stress or mental scenario than it does physically after a while. But I would just stress asking the right questions and being on top of the information is what I would stress.
Absolutely. And I think it's really great that you were able to talk to your father, and Dr. Northfelt and Dr. Coburn can both speak to the importance of knowing your family history, especially when it comes to knowing what cancer is running your family and being able to have those conversations. Again, thank you for sharing, Mr. Walker, and we will have time for questions towards the end, but I will pass it over to Dr. Northfelt.
Thank you, Christine. Mr. Walker, I want to say how grateful we are for the way you told your story, because it's a perfect example of how a person takes charge of their health care and makes something good happen for themselves. And I'm also grateful that you have the courage to bring it up in a group experience like this. I'm going to make a few points really just based on what you heard a moment ago from Mr. Walker. First of all, prostate cancer is a pretty common cancer. It's a very common cancer in men in America. About 250,000 or so people in America diagnosed with prostate cancer each year. It is a curable cancer. And again, you just heard it from Mr. Walker. There are treatments available today, surgery, radiation treatments, some medical treatments that can cure prostate cancer. So it's something to take seriously, certainly, but understand that if you're diagnosed with prostate cancer, if you follow the right steps like Mr. Walker did, you can be cured. So it's nothing to fear in that sense. It's nobody wants prostate cancer, but if it happens to you, take charge of it and get it cured, just as Mr. Walker did. There are approximately, as I said, 250,000 men in the United States diagnosed with prostate cancer every year. but only about 40 to 50,000 deaths from prostate cancer every year. So if there are 250,000 men diagnosed every year, but only 40,000 dying every year, that means the vast majority of patients with prostate cancer are being cured. So we're having tremendous success in the 21st century curing prostate cancer. However, it's very important to follow Mr. Walker's advice, which is catch it early, because the cures are going to come to those people who have their cancer found early when it's limited to the prostate gland and can be treated effectively with radiation and surgery, or radiation or surgery. Once the cancer has spread outside of the prostate gland, it becomes much more difficult to achieve a cure. So this business about getting screened and catching it early and getting treatment early is crucial to having a successful outcome with prostate cancer. So please do as Mr. Walker did, catch it early, get it treated effectively so that you can be cured. All right, that's the good news. Prostate cancer can be cured. What's the bad news? Well, if I'm talking to an audience of Black men, I must tell you that you're more likely to develop prostate cancer than white men. Christine brought it up at the beginning. In white men, the lifetime incidence of prostate cancer is about 1 in 8. So 1 out of every 8 white men over the course of their lifetime will develop prostate cancer. It's 1 in 6 in Black men. So it's substantially more likely that a Black man in America over the course of his lifetime will develop prostate cancer. And this is why speaking to the audience that we're speaking to today is so crucial. We need all the Black men in the audience and all the women who know Black men to get this word out that prostate cancer is more common in Black men. With screening, however, just as Mr. Walker demonstrated, it can be cured just as effectively in Black men as it can in white men. So the screening and the early detection and the early treatment is absolutely critical to being successful with prostate cancer, regardless of your race. As Mr. Walker illustrated with his story, there's radiation treatments that can cure prostate cancer. There are surgical treatments that can cure prostate cancer. Sometimes we use medical treatments as well. The final thing I'll say is that even when prostate cancer is advanced, even when it cannot be cured because it has spread, there are very effective treatments to control prostate cancer, to keep it in check, and to keep people well. So it's very critical that prostate cancer be treated by doctors who know what they're doing, be treated effectively to keep a person well, even in those circumstances where it cannot be cured. I want to say something about why it happens that Black men are less successful in their treatment for prostate cancer, why more Black men die of prostate cancer than white men. Unfortunately, racism plays a very important role in preventing Black men from getting the treatment that they need to be successful with prostate cancer. And this is a historical thing. We've known for decades that Black men have less access to the proper care for curing these cancers. There may be barriers in communication. Doctors often don't know how to talk to Black men in an effective, clear manner. This is why it's so important to follow Mr. Walker's advice and ask questions. I want every Black man in this audience to understand that your doctors work for you. Your doctors work for you. So when something is said that doesn't make sense, stop that doctor and say, what are you talking about? What do you mean by that? I want to understand this. Explain that to me. Your doctors work for you, and you should not accept less than a complete answer to your question. Don't accept less than a complete explanation of what's going on with your disease and what your treatments can accomplish. Our goal, obviously, is to erase these discrepancies. We don't want Black men to experience any less success in treating prostate cancer than white men, but we have a lot of work to do to achieve that. We need to make sure that Black men are getting screened effectively to find prostate cancer early when it's curable just as Mr. Walker illustrated. We need to break down these barriers of racism that exist that prevent Black men from getting the treatment that they need to be successful. These are efforts that are going on all the time at Mayo Clinic and places like Mayo Clinic. So wherever you are in the country, get with a team, get with a group that knows how to take care of you. Be aggressive and be certain that the care that you're getting is understandable and effective. I'll stop there, and I hope that we'll have some questions about this as we move through the hour. Very much appreciate the opportunity to speak to everyone today. Thank you.
Thank you, Dr. Norfelt. And I think that's something that we can all take away is your doctor works for you and making sure that you get your questions. Thank you. Your answers, your questions answered, excuse me. And now we'll pass it to Dr. Ewan Coburn.
Thank you, Christine. Dr. Norfelt, thank you for your comments. And Mr. Walker, thank you for sharing your story. You provided us, you set the stage with a lot of detail, and your story was very reflective of your journey. And so thank you for sharing your cancer journey. We're going to transition just a little bit. We're going to talk about the impact of genetics and genetic literacy on prostate cancer outcomes or prostate cancer, localized prostate cancer. And so I'm just going to briefly, I have a few slides. By no means are these slides meant to be exhaustive on the topic, but I think for our conversation, I wanted to be able to just present a few slides. I'm going to share screen and then talk briefly about once again, the topic, genetic literacy and patient caregiver communication of, these are genomics for localized prostate cancer. I couldn't talk about this topic without talking about how do we build relationships in diverse community. So very often when we go into communities, we have an informed consent, right? And we inform the study participants about the studies that we're working on, and that's pretty much it. And then we think as if that because we've given you informed consent, that will kind of continue building trust and relationships with diverse population. And so these researchers here, they wrote an article, and they essentially says that we need to move beyond informed consent or beyond consent, so that as we are looking to build relationships in diverse community, these are African-American community, Hispanic community, Native American communities, specifically around precision medicine. And precision medicine is the use of genetics, genomics, and personalized medicine as we're looking at prostate cancer and disease outcomes. And so those are some of the things that I wanted to talk about. Briefly, the National Comprehensive Cancer Network recommends that patients and clinicians consider tissue-based tests for localized prostate cancer in the notion that this can help patients and their caregiver make more informed decisions at the time of diagnosis. And so I'll stop here. I don't want to infer or anything, but as Mr. Walker was going through his prostate cancer journey, a lot of the innovations that we're seeing in genomics, they're now coming out at, you can do a test of the tissue, the biopsy tissue. So when you're doing that biopsy to kind of determine grade and stage, there is also a test that allows you to be able to look at the genomic profile of the tumor to see how aggressive the tumor is likely to perform. What we're seeing in underserved community is that there is lack of understanding about genetics. And so I have a study that I'm working on across the Mayo Enterprise, Jacksonville, Arizona, and Rochester, where we're trying to increase patient caregiver understanding of genomics, of genetics. And so that's what I'm going to briefly talk about. So these kind of tools are Polaris, Oncotype DX, and Decipher, and these are multi-gene expression panels, which offer new approaches for categorizing patients according to their level and risk of reoccurrences. So essentially what we did, we wanted to increase patient understanding of genetics and genomics, patient and their caregiver. So we decided to create an educational tool, an educational video that essentially would just talk about the various elements. What is prostate cancer? What is genetics? What is genomics? What is precision medicine? And like Mr. Walker, we recruited 2 patients One patient, this patient here, he's a white male, and he essentially told us about his prostate cancer treatment journey, and he told us about his experience using one of these genetic profiling platforms to kind of help him to make a decision on whether or not to treat. We also have another patient who's a Black male, so we created two videos, one for white males because we're interested in rural underserved communities, rural white underserved communities. We want to understand or how we can improve or increase patient understanding of genetics and genomics and precision medicine in the rural white underserved community. And we also have an educational video that's tailored for African American men. We recruited a couple of physicians to be able to, this is me interviewing a couple of physicians, and they're just telling us about prostate cancer, the incidents, walking us through at a very simple level so that it's an educational tool, and we want it to be at the level that the patients and the caregiver, as they're going through the process of being diagnosed and even going through the process of prostate cancer treatment, to be able to have this as a resource to be able to understand some of the things that their questions that they may have about prostate cancer, and what's this genomics piece. So other physicians as well. So our study, I don't want to go too much into this study because I really want this to be a conversation. The first specific aim of our study is to really examine patients and caregivers' comprehension of genomic technology for localized prostate cancer. And so this is just a mixed method study that we're doing 12 focus groups. And then the second aim of our study is to we created this educational video, and what essentially we wanted to see, does the educational video plus patient education and coaching, does that improve patient caregiver comprehension or communication of prostate cancer genomics? And so this is a randomized control study. Don't want to go into the nuts and the bolts of it, but essentially what we did before implementing this study, we decided to recruit a very diverse community advisory board in Jacksonville, a community advisory board in Arizona, and a community advisory board in Rochester. And so what is a community advisory board? A community advisory board are key community stakeholders or key community individuals that will come to the table, and they will review every single part of our protocol. With their review and the educational video that we created. This is an example of the Community Advisory Board in Jacksonville. They're reviewing the actual recruitment material. And so we had the Community Advisory Board in Jacksonville and Arizona essentially review the entire study protocol. And I'm going up to Rochester in a week where we're going to convene a rural community advisory board with rural white men and African-American men as well. And we're really having them going through the actual full study protocol. Is the way that we're doing this study, is it building trust within the community? So back to the article that we talked about earlier, how can we build trust? How can we have a multi-directional, bi-directional communication as we're doing studies like this that are impacting the community? And so the first flyer is tailored for African-American patients. The second flyer is tailored for rural white patients. And so as you can see, the Community Advisory Board is very active in giving us feedback. And so we're taking those feedback. They're giving us feedback on the video. We're taking the feedback to heart, and we're changing and we're implementing, and we are re-editing the video. We're going to re-edit the flyers to make them a little bit more sensitive to the need for both of these communities as well. So essentially, I'm going to present just some brief results of the Community Advisory Board in Jacksonville. So this was a 15-member community advisory board, and we divided them into groups of 5 for focus groups discussion. We did some qualitative and quantitative assessment, really more so to look at facilitators and barriers to the understanding of genetic literacy or genetic and health literacy in underserved community. So I'm just going to talk briefly about some of the things that we found. So results-wise, the Community Advisory Board, doing their focus group, they talked about lack of awareness about genetic testing. So this is tumor-based genetic testing. Most participants indicated that they were not aware of tissue-based testing or its availability to them. And so these are some of the things that we're seeing in underserved community. In one of the groups, one participant acknowledged the importance of defining and clarifying the term tissue-based genetic testing to help further inform decisions. And so caregivers and prostate cancer survivors, they want to have a better understanding of health literacy, genetic literacy, and as it relates to prostate cancer outcomes. Encourage conversation about genetic testing. And so these were some of the recommendations. Encourage open discussion with families in the communities and with primary care physician about the importance of genetic testing, some of the risks and then the benefits of early detection. So once again, Dr. Northwell talked about early detection. Mr. Walker talked about early detection. And so early detection is key because there's so many things that there's so many options you have available to you when you're diagnosed early. And I'll just share here briefly, my grandfather was diagnosed with prostate cancer, and he was a survivor for a very long period of time. My grandmother was diagnosed with stage 4 breast cancer, and she did not have a lot of options. She passed away 4 months after diagnosis because she was diagnosed so late with breast cancer. And so this is one of the reasons why I'm passionate about prostate cancer outcomes, but not just that, but just in general, cancer outcomes in underserved communities, because I think that there's oftentimes barriers to early detection and early treatment. And so those are some of the things that we have to be aware of. So essentially the Community Advisory Board talked about highlighting the complexity surrounding prostate cancer and the need for further education, awareness, and access to affordable care. And so that's one of the things that we intend to do with this research study, is to improve education and awareness as it relates to genetics and genomics and so on. So this is just a picture of the Jacksonville Advisory Board, and then here is the Arizona Advisory Board. And then very, very often this empty space here, it's not by accident, because the Rochester Advisory Board, we're in the process, we've recruited about 7 individuals from rural Rochester, and we're going to be heading to Rochester very soon to be able to do their community advisory board. And I really take it to heart that this is really true community partnership in that. So we're partnering with the community to be able to understand some of these issues and the challenges that we're seeing as it relates to genetics, health disparities, health equity, also health literacy in underserved community. And so I'm going to stop here. I'm going to stop sharing here, and I'm going to open the floor. I'm going to turn it back over to Christine, so that we can answer a couple of questions. So thank you so much, and just thank you overall for just allowing us to have this conversation about prostate cancer, doing this Prostate Cancer Awareness Month.
Thank you, Dr. Coburn. There was a couple questions in the chat, and I know Dr. Northfelt has the answers to those.
Yeah, thank you, Christine, and thank you, Dr. Coburn. You know, I hope everybody who's participating today realizes how lucky I am to have Dr. Coburn as a colleague at Mayo Clinic, because he's asking some very specific questions about how we can do better in taking care of Black men with prostate cancer. And he's going to help me in my work to do a better job. So I'm looking forward to all those new insights that Dr. Coburn provides to us through his research. So thank you, Dr. Coburn, for that. Mr. Stephen Taylor, I'm calling you out, sir, because you're asking some very good questions, and you're kind of leading the way here for everybody else on the chat. So during the presentation by Mr. Walker, Mr. Taylor asked a question about incontinence, and I wanted to address that. It is true that some prostate cancer treatments can lead to incontinence, where it's hard to hold on to your urine. And that can happen either with the surgical treatments or with the radiation treatments. The urologists, who are the plumbers of medicine, they have great strategies for helping our patients who develop incontinence. That can be with medication, or it can be with some very simple surgical procedures to help with incontinence. So when we send a patient into treatment for prostate cancer, our hope and our intention is that they won't have incontinence when they're finished with their treatment, but it is a possibility, and we have methods for dealing with that when it occurs. Mr. Taylor also asked a question during my presentation. I was talking about what the likelihood is that a white man in America will develop prostate cancer over his lifetime, and what is the likelihood that a black man in America will develop prostate cancer over his lifetime. So Mr. Taylor said, what about Hispanics, Asians, and Native Americans? Is their incidence the same or lower than others? And in general, those other groups that he mentioned have a lower incidence of prostate cancer. However, the same message that we're giving to everybody with prostate cancer applies regardless of your race or ethnicity. Screening is crucial to finding prostate cancer early when it can be treated effectively and cured. So screening recommendations go out to every man in America, regardless of race, regardless of ethnicity. It is recommended by the American Cancer Society that Black men start prostate cancer screening a little bit earlier in life. And that recommendation was made by the American Cancer Society in recognition of the fact that Black men can develop prostate cancer earlier in life. We want to catch those cancers early when they are treatable, curable, especially in young men. We want you young men to have a long, healthy life. We don't want prostate cancer shortening your life. So we start screening in Black men a little bit earlier than in other racial ethnic groups. It's recommended by the American Cancer Society that Black men start prostate cancer screening at age 45. Now, when I'm talking about prostate cancer screening, I'm talking about a blood test. In the old days, it would be a digital rectal exam, and a lot of people didn't favor that because it can be uncomfortable. Prostate cancer screening with a PSA, that's a blood test. That's a poke in the arm to get a sample of blood. It can be done at the same time that you're getting your cholesterol checked or you're getting your hemoglobin A1C checked if you're diabetic. So one poke in the arm, you can get numerous things checked. And your PSA, prostate cancer screening, should be an annual part of your checkups when you're wanting to identify prostate cancer early when it can be cured. Let's see, we've got some other questions. I don't know if you want to take these questions and scatter them around, Christine.
We have Martin with his hand up, so I'm going to call on our tech help to help us unmute Martin so he can ask this question.
And then Christine, Mr. Walker mentioned that he can talk a little bit on incontinence from the survivor perspective.
Yes. So Martin, we'll let you go, and then Mr. Walker will let you address that next.
Yes, this is Martin Buez in the Department of Radiation Oncology. First of all, I'm not aware that I did raise my hand, but I would just like to mention that I am very glad to be here and listen to this very informative presentation, especially from a patient perspective. So we in radiation oncology, of course, see a lot of prostate patients. And I would just like to maybe also mention, while I'm being called upon, that there is a special mode of radiation therapy that we offer here at the Mayo Clinic in Arizona and also in Rochester, called proton beam therapy, which is actually a very attractive mode of radiation therapy, particularly for prostate patients. Thank you.
Thank you. And we will turn it over to you, Mr. Walker.
Okay. Speaking on incontinence, which we saw, we had a question from the one of the listeners, and speaking toward what Dr. Corbin and Dr. Northfield have already stated, my deal with incontinence, no, I can't hold my urine like I used to could. I could, used to could hold it. I guess, men kind of pride themselves on that type of stuff sometimes, but that is weakened after the radiation treatment. It's not to a point of any type of embarrassment or any type of thing like that. Maybe like overnight, and I usually have to get up and use the bathroom almost at the same time every night. Um, here after the treatments and everything, but it's not anything and I guess some of this goes back to how severe the prostate cancer is. I can't really speak on that, but like I said, mine was caught early, so maybe my treatments weren't as severe as maybe some of the other survivors that I've talked to and spoken with. But the incontinence, my physician, urologist did speak about that right from the very beginning, about maybe small little lifestyle changes you might have to have. And he said since I was younger that I might not have some of the more severe or maybe potentially embarrassing scenarios of leakage, maybe having to wear Depends, all that type of stuff. Mine has been very minimal when it comes to incontinence. Uh, and like I said, maybe mine was just because, like I said, it was caught early, and like I said, it's somewhat minimal, but it was noticeable at the beginning, but it has started to deteriorate as I proceed with moving forward.
Thank you. And we have another question in the chat that says, any prevention tips with nutrition, supplements, etc., or things as advertised on the radio?
I'd be happy to try to take that one, Christine. First of all, I want to say to Mr. Walker, thank you for your input. And you can probably tell from the color of my hair that I'm a little bit older than you, sir, but I have to get up every night at about the same time as well, and I haven't had prostate cancer. So, that's something that definitely can happen, right? Now, Dr. Thomas has put a question in about prevention tips with lycopene, nutrition, supplements, such as saw palmetto, which is advertised on the radio. In the Mayo Clinic, we're making recommendations and giving advice that's based on scientific research. There are a lot of strategies for healthcare that exist outside of science-based strategies, and that's not to say that there's anything wrong with them. It's just that it's a little more, it limits us. I'm sorry, I should say it limits us a bit at the Mayo Clinic in what we can say about strategies that don't have a scientific basis behind them. However, I will tell you that there's a lot of anecdotal information, meaning people have given testimony about the benefits of various nutritional strategies to help with cancer problems. I think the one thing that I can say that's pretty well supported by evidence is that when we follow an anti-inflammatory diet, in other words, a diet that works against inflammation in our bodies, that can have a very good effect against cancer problems. What's an anti-inflammatory diet? Well, it's a plant-based diet. It's one that emphasizes that most of your nutrition comes from plants. Another way to state it is that if you followed what's called a Mediterranean diet, you'd be following an anti-inflammatory diet. The thought is that animal products, beef, pork, dairy, these are things that can increase the inflammation in our body. And the worry is that cancer feeds on inflammation in our body. That means that if we do things that can limit the amount of inflammation that we're experiencing, in other words, eat a healthy diet that limits the amount of inflammation that's generated within us, that can be a way to help against cancer problems. So I'm not here to speak about any specific diet or specific supplement that's important for prostate health or prostate cancer health, but in general, eating an anti-inflammatory diet is a good way to reduce inflammation in our bodies as a way to limit cancer problems.
Thank you, Dr. Northfeld. And I see William has his hand raised.
Thanks. Unmute your microphone, William. Sorry, this is William Wong. I'm the chair of radiation oncology at Mayo Clinic, Arizona. I just want to say is I'm just so glad to hear all the comments from the participants in this discussion, and I want to add on to what Dr. Norfeld has said about diet. I don't think there's a specific diet that's prostate cancer specific, but usually when patients ask that question to me, I would tell them a healthy diet basically is exactly the same kind of diet that Dr. Norfeld would propose. A lot of vegetable, fruits, less red meat, a lot of exercise included. That would be good for the whole body as well as good for the prostate.
Thank you. Are there any additional questions?
Could I ask a question of Dr. Cobran?
Sure, absolutely.
Yeah. So, Dr. Cobran, I imagine you have a hypothesis. In other words, you have an idea about what you're going to learn when you survey Black men for their knowledge and understanding of the genetics of prostate cancer. Could you speak a little bit about I know you don't have the results of the study yet, but just speak about what you expect to learn, because I think our audience would like to know what's in your head about these issues.
Sure, Dr. Norfeld, that's a very good question. So what we're doing, we're using a validated survey instrument that talks about knowledge of genetics for prostate cancer. And so these are validated instrument. And essentially what we're doing a pre and a post. So before the educational tool, the nurse coaching or any of that piece, we're giving the patient and the caregiver, or the man and it's a diet. So diets are, it's a couple. So the way that we're thinking about it is that at the end of the day, we just want to increase knowledge of literacy between the patient and the caregiver, whoever the caregiver is. And so what we've seen thus far in the literature is that we are seeing that there is little knowledge of genetics, and then there's a fear in underserved communities. We talk about Henrietta Lacks and using cell lines without the family's knowledge. And so in certain communities, there are fears as it relates to genetics and genomics. And so because of those fears, what we're seeing is that there's a little bit of apprehension. And so we're having to go in, and the reason why we're pulling together these community advisory boards is that we are trying to figure out how do we build trust in the various different communities that we're entering in, so that we can, at the end of the day, we just want to improve understanding and literacy and knowledge of genetics. And so at this point, the first phase of this study is just to increase awareness, improve knowledge, and that's what we're focusing on. And so that's a very good question.
Thank you. And go ahead, Dr. Nelfront.
Yeah, I'm sorry to jump on you there, Christine, but I saw that question as well. Thank you, Dr. Cobran, by the way. So there's a concern among men who may be diagnosed with prostate cancer that the treatment is going to affect their sexual function. And I'm so grateful that the questioner brought that up. When the man meets with the urologist or with the radiation oncologist to talk about treatment, one of the things that will be discussed is what impact will surgery or radiation have on sexual function. Now, in the bad old days, it was very likely that the kind of surgery that was performed for prostate cancer would result in impotence. And it was somewhat likely that radiation treatments for prostate cancer would result in impotence. Over the years, though, the surgeons and the radiation oncologists have refined their techniques to spare a man's ability to have sexual function and at the same time get effective treatment for their prostate cancer. So in the 21st century, there's less of a worry that prostate cancer treatment is going to affect sexual function. Now, again, when the man meets with the urologist or the radiation oncologist, there will be a discussion about this, and the radiation oncologist, the urologist will say there is some potential for these treatments to affect your sexual function. They will then go on to say, here are the remedies that we can offer if that happens. And there are a variety of remedies that the urologist, the radiation oncologist can offer to improve sexual function in the aftermath of prostate cancer treatment. I'm sure everybody on the call has heard of Viagra. Okay, well, that's something that works even if sexual function has been diminished by prostate cancer treatment. So there are medical remedies like that that are available. And there are other remedies as well. I'm not an expert to speak on these things, but I know that men whose sexual function is affected by prostate cancer treatment have remedies available that can restore that for them. So it's a worry, and it's definitely a concern that will be discussed when the urologist or the radiation oncologist meet with a man with a new prostate cancer diagnosis. We want men with prostate cancer to receive curative treatment. We want them to be cured of prostate cancer, but we want them to go forward in life functioning as completely as they wish. And that's always going to be the goal when the radiation oncologist, the urologist meets with a man with a new prostate cancer diagnosis. Mr. Taylor says, doesn't sexual activity increase testosterone, which feeds prostate cancer? I think, sir, it's actually the other way around. Testosterone feeds sexual activity. And, you know, this is a situation where, again, the urologist, the medical oncologist, the radiation oncologist know how to work with a man's testosterone and with some of these other strategies to improve or maintain sexual function, even if the testosterone is being affected by the prostate cancer treatment. So again, you know, this whole conversation gets back around to how is my sexuality going to be affected by my prostate cancer treatment? There are answers for that. That's part of the discussion that the urologist, the radiation oncologist will have with a man with a new diagnosis, so that that man can go forward with confidence that his prostate cancer can be treated and cured and his sexual function can be preserved. Mr. Walker, please.
Yes, Dr. Northfeld. Honestly, my urologist, one of my first early visits, we kind of covered a lot of what you are speaking about now and previously. When they ran the first test to see if I indeed had prostate cancer, it wasn't, as he explained, it wasn't as barbaric and uncomfortable as you mentioned, like it was previously. You know, with modern technology and modern medicine, the way that they treat prostate cancer has, you know, improved by leaps and bounds. It's not like it was, let's say, even 20 years ago, which I found out everything was relatively painless and smooth sailing. I mean, yes, and like I said, it affects everyone differently, but they assured me, and we already kind of had everything mapped out before it actually happened. As far as the sexual activity is concerned, that was also addressed. Like you said, there's Viagra. You see these commercials for, was it Nucigenics, which is testosterone. Those are all remedies or that type of deal toward increasing your testosterone, which increases your sexual activity and appetite and what have you. There's numerous, like you said, options to Viagra and different, you know, medication that can be prescribed for you for this scenario. Speaking personally, has it affected my sexual activity? Yes, slightly. But again, I'm still just really 2 years removed. So I'm not, hasn't just necessarily been all downhill. But I mean, you have to have an open mind to be able to want to try different things and be open-minded to, like you said, different pills and vitamins and what have you that can get you where you're trying to get to.
Thank you. And I know we only have 3 minutes left, and there is one additional question in the chat. It says, if any time to answer, BPH and prostate cancer risks, latest in literature.
Yeah, just quickly, BPH is an acronym for benign prostatic hypertrophy. That's medical jargon to say your prostate is big, and as men age, I don't have to tell you, as men age, it gets to be more of a problem. It can be challenging to differentiate these two, especially when the prostate cancer is early. So it's the PSA is still relatively low. BPH can cause prostate cancer, or sorry, PSA to rise. And so it can be a little challenging for the doctor to discern exactly what's going on. There may be a slightly greater chance that a person with BPH develops prostate cancer, but there's not a really tight link between these two. I think anybody with BPH ought to be in care, ought to be seeing a doctor and having that managed and having PSAs done so that if prostate cancer does emerge from BPH, that the person can be right on top of that and get the care that they need.
Thank you, Dr. Northfelt. Thank you, Mr. Walker, for sharing your journey with us. I think we all greatly appreciate it. And thank you, Dr. Northfelt and Dr. Coburn, for bringing your knowledge to us as well. And I think one thing that we can all walk away with is from Dr. Northfelt is your doctor works for you, asking those tough questions, getting the answers. And if you don't understand, go back and ask the question again. Thank you all so much, everyone, for attending, and we greatly appreciate all of your questions. There is a link in the chat to complete and give us some feedback on the session for today. And we'll stay on here just for a couple minutes so you can click that link and take the survey. Thank you. Any final words from anyone?
Really grateful for everybody's participation and attention, and especially grateful to Dr. Coburn for his input and to Mr. Walker most of all, because I think the comments Mr. Walker made were worth everything that the rest of us said.
I would just like to say, please go and get checked, regardless of Black, white, Asian. If there are any women in here, trust me, you have the inside track to go and have any man get checked for prostate cancer or going to the doctor for anything. Most men are not trying to go to the doctor. Women are, I'm pretty sure the doctors would tell you their percentage rate of needing to go or wanting to go to the hospital, doctor, or whatever for checkup is way higher than men. Women, if you say anything to a man about going to get his prostate checked, I assure you, you're heading in the right direction. That would benefit him greatly. Thank you. Appreciate you all having me here.
Thank you.